Good morning, this is Roy Lilley from a freezing cold London. As you can see, the glamorous end is down there with the wheel that was the centrepiece for the fireworks on New Year's Eve. But this rather unprepossessing building, this anonymous lump of glass, is actually the temporary home of the Department of Health and Social Care. They've moved out of Whitehall because of the renovations in Westminster. Means that part of Westminster is moving into the old building of the Department of Health in Whitehall opposite Downing Street. So that's why I'm here. Why am I here? Well, I'm here to talk to Dame Sally Davies, the Chief Medical Officer, about her annual report. This year I really quite liked, so I'm going to talk to her about it. So come on in. This is Roy Lilley and I'm with Dame Sally Davies, the Chief Medical Officer, and we're here to talk about her annual report. Now, regular viewers, readers of my stuff will know I'm not desperately keen on annual reports. However, on this occasion, not just because I'm within reaching distance, but on this occasion, I actually, in all seriousness, it's a great report. If you haven't read it, follow the link and have a look at it. It's a lump to read. But it's excellent. Now, what were you trying to achieve with the report this year?
So I think one of the pleasures of my job is being allowed to think and talk to the best minds in Britain and across the world. And as I look at the NHS, and I've given my life to the NHS, I care desperately about it, what's clear is that my colleagues, the doctors, the nurses, are working flat out, and they can't lift their heads up to say, where should we be going? And in a sense, I wanted to look forward to 2040, far enough away that it's not next week, and say, this is what the future could look like. Because I think people find their own different paths, and locally you may want to do things differently. But you need a shared view, and I think we all need a vision, the Holy Grail, where are we aiming for? And that was what I went out to do. What could health look like in 2040?
Leaders have a vision, are visible, and share it off.
Absolutely.
For me, the report is in sort of two bits. There's the chocolate muffin bit, you know, don't eat them like we don't know chocolate muffins and a full fat latte are going to make us fat. And you're having a poke again at the industry. And you talk about fiscal, whatever the phrase was, I forget what it was now, but I mean in English it means put the prices up or use pricing as a mechanism to disincentivise us eating chocolate muffins and full fat lattes. Talk to me about that, because what's the evidence that that works?
Oh, there's quite a bit of evidence. So first we have to move past the fact that obesity is just a failure of our personal strength to refuse food. Nice work on automaticity, but let me describe it this way. I go to a party and a nice canapé goes past. I like food. I've eaten it and then I think, oh shit, I wasn't supposed to. You know, I've had enough food today, or generally. And it is just very easy to eat too much. We've got an unbalanced environment where high calorie, not terribly good foods are cheap and they're in your face all the time. And that's driven by industry and profit. And we need to rebalance our environment to make it easier to have the healthy choice.
Is it? I mean, if you're a mum with not a great deal of money and your kids are hungry, a bag of chips is cheap, it's tasty, it fills them up. It's not quite the middle class choices, is it?
I absolutely agree. And I too gave chips to my children and things. But if actually you're that poor, usually you're also worrying about getting enough calories. What I want to see is that we make the unhealthy foods more difficult to reach. There's very nice evidence, again you'll say it's middle class, but it is evidence in cafeterias that people go for the food that's closest. So if you put salad close to them, they will reach it. There's evidence about checkouts, where if there are unhealthy sweets and foods, children, over 70% of parents have been pestered by children to buy them. If they're not there, the children don't.
And most supermarkets have, in fairness, haven't they, moved them? Look,
they have, because we put pressure on them.
Yes, and that's the point really I wanted to make with you. We seem to go around in a loop with this. You know, you make perfectly sensible recommendations. Government should do this, government should do that, and government says thanks very much. You know, that's public health's job. And public health, and I've interviewed the boss of public health. You know, and he sort of sits and wrings his hands and said, "Well, we make recommendations, and it's up to the government to do something." And it's like nobody is saying we need to do this stuff. I mean, they're not going to take on the food industry in the way that we would like, because, you know, it's kind of too difficult.
They will take on the food industry.
You've heard it here first. They will.
We have to call time on it. Take smoking. At the end of the war, 1 in 2 men smoked. And eventually, because we'd socialised the harm and the need to do something about it, governments saw they wouldn't lose votes and that they could take them on. It takes time.
Well,
all of this is about preparing the ground, socialising it, showing what can work and how it can work.
Right, that's the difference, I think, between Jon Snow as the public health doyen of his day, Data and the dirty pump, and that's how everybody got typhoid or whatever it was, and Thomas McEwen, who I really rather favour. Thomas McEwen said, in terms, governments have done everything they can do about public health: adult literacy, clean water, child immunisation. The rest is the extent to which governments will interfere in the lives of ordinary people. It's the law that changes behaviour. Tony Blair introduced a law to abolish smoking in the workplace. It's the law. Now, what law do you pass to make fat people thin?
Take the sugar levy on sweetened drinks. That has caused most of the companies to reformulate, rather than taking out 450,000 kilograms of sugar a year out, rather than price more expensively for families. So by that law, the sugar levy, we have reduced calorie consumption. And actually, I think that needs extending.
And you're pushing on to
drinks.
milky drinks, and that's one of your recommendations,
yes.
isn't it? Do you get any sense the government's up for this?
I'm sure we're going to go there. It is only a question of time.
Yeah, I guess they've got one or two other things to think about. Another thing that interested me about the report are the social determinants of health. Now, we kind of talk about that in a very casual way. You know, it's a phrase everybody uses, but in the report, I think it's on page 146, there's a fantastic set of graphs, right, where the social determinants of just about every disease, illness, and what could befall people is there in a graph. And in every case, lower social classes, poorer people come off worse. In every case, they come off worse. Discuss.
So I think it's absolutely shocking. I agree with you. And Michelle Coleman has given us in this report work that isn't yet published, showing, for instance, for cancer, that if you're in the most deprived groups, 10,000 people extra die over the 5 years from diagnosis at the present time. Those are preventable deaths. And actually, that's one of the interesting things in this report, that the NHS is not just an ill health service, it isn't delivering the best treatment service, and we have a role in public health for the NHS.
I thought that's
well
really, because you're talking about, aren't you?
Composite health.
Yeah, I mean that's you look at that and you think that, you know, the government is never going to do this because it's another big IT project. But reassure me.
No, I don't want a big IT project. I lived through the last.
Connecting for health.
Yes.
Do you have the scars? We all do.
Yes.
Yeah.
No. So I am arguing that we should treat health as a primary asset in this nation, and we've got a wonderful chapter on health and what it brings to the economy, let alone well-being and happiness. But I also argue that what gets measured gets done. And I think that our present measures are not good enough of GDP. The well-being index is interesting, but actually a bit irrelevant for making us shift what we do. So I want a composite health index that looks at social determinants, that looks at modifiable risk factors and outcomes. So some of the things are, you would perhaps use the ratio between the neonatal mortality in our most deprived and our best off. You would look at healthy life expectancy and use those ratios and put them together. And you can build these composite indexes. I've talked to people from the World Bank, I've talked to people from OECD. They're really excited at this.
Is there anywhere
idea.
else that's doing it?
Not in this form yet, but we're going to have a meeting soon and have a look at what we can do from government.
And we've got the data, but it's
We
just
have the
not
data,
all in
it's
the
not
right
measuring,
place.
I'm not asking for new measurements, that's
No.
costly and anyway do we need it. I'm saying let's put it together and get the best
It is
statistical
interesting
grades
because
on
the
it.
private sector do it, don't they? I mean, if you buy something on Amazon, they remember you and they know
do.
what you want to buy next time. If you buy something on a holiday, if you buy a holiday, they remember that. And I remember speaking at a conference, there was a company, I think they've gone there, called TNS Acorn at the time, and they put all these things together. So when you tick the T's and C's and you buy something, no one ever reads it, but what they say is we're going to put your data alongside everything else. And they could do down to a postcode, lifestyle determinants, down to a postcode level, because they knew what you bought, when you bought it, where, all of that. So the data is there, isn't it, to do?
So I'd like us, you're moving on to the whole data section in the report, to not only harness AI, artificial intelligence as it goes forward, but actually look at how, with patients and the public, we harness these other data sets about them and bring them together. And the only way we'll be able to do that is with machine learning. And
Yeah, well,
AI.
before we, I mean, that's the bit that I must say really caught my attention. But before we do, I want to come back to this social determinants thing. I remember Gordon Brown, I asked him once, what are you going to do about poor people? And he said, make them wealthy. And it is, I mean, that's a very grand answer, isn't it? But that's what it's about, isn't it, really? You can't, what do you do when the social determinants of health are so in your face, so obvious? What do you do? It's a much bigger thing, isn't it? It's a whole economic thing, it's work, 3 determinants of public health, isn't it? A job, a safe place to live, and someone to love.
Yeah.
Can we do that?
We can do a lot more than we do, even without a lot more money. We, at the moment, provide, for example, screening services that are just provided generally in the same way across the country. We're not progressive. We don't segment people and say what is the service they need because of their problems, their issues, their cultures, their ethnicity, their approach to the system. How do we shape what we're delivering to bring them in and give them the services they deserve?
And you've got a rather cunning recommendation, actually, which nobody seems to have picked up, and that's you want NICE to look at effectively comorbidities in one person. I mean, at the moment, say, oh yeah, your granny's got 5 comorbidities. That means like she's got 5 things wrong with her that would have killed her 10 years ago, but today we live to 100 with them. But that, of course, does develop a whole different medical shape, framework, template. I don't know what it is, but we don't actually look at patients as a whole, do we? Tell us about, where did that come from?
Well, colleagues have been talking in this sort of way for a while, and what Chris Whitty has done in his chapter is bring it together, and I was very keen to give it airspace, because if you're obese and you develop diabetes, then you might be seeing the weight management people, you'll be seeing the people about your A1C and your blood sugar, then you'll get high blood pressure, and it might be the same nurse that does that, but it might be a different clinic. What happens when you need your eyes looking at, your feet looking at, your ulcers looking at, and your renal failure? It needs to be looked at as a multimorbidity kind of cohesive group. And we need, instead of a guideline for each of those things separately, we need guidelines that treat people as a whole.
Does that
where
tell us
the underlying pathology is all related?
Does that tell us that we want a different ologist or a different
We need to go back to generalism.
Yes, do you remember general surgeons?
Yes.
Yeah. And there were general medical people. Well, and I suppose the closest we get to it are geriatricians, who are hugely undervalued.
They're wonderful.
They're very clever people, yeah. So maybe we need to think about work and workforce with this.
I think we need to, and training. And we also, because a lot of this is in the community, in primary care, we need to think about how we task shift, how are we preparing nurses to do more than one of those things on one day, and support them to do it effectively. And then you get into the digital support. You can have the bots on your apps and what role they can play in triaging and advising.
Well, look, I'm now going to get into AI, digital technologies, and all that other good stuff.
So I'm Johnny Pearson-Stuttard. I'm Editor-in-Chief of CMO's annual report this year. My background is I'm a public health registrar and an academic up at Imperial College London.
Public health? Right. We've done public health, Johnny. We're going to get on to we've done that without you. Is that okay? I want to talk about the IT and all that stuff. Okay. Now, look, this is a no-brainer, isn't it? Everywhere else you go, you get AI. Everywhere else you go, you get data captured and shared and all the rest of it. But in the NHS, we're still terrified of data. Fiona Caldicott has frightened everybody. Witless, the GDPR thing has now made everybody completely wary of doing anything with data. First line to get over really is data sharing. I mean, I was in Liverpool, it was a couple of years ago now, Healthy Liverpool. It's a fantastic project there. But to get it off the ground, they had 3,000 data sharing agreements, 3,000. Now, they've come on a bit since then and they've sorted stuff out. But before we talk about, we need to make better use of data, what do we do to make better use of data? It's not that easy, is it?
Well, I think a lot of it comes down to trust and understanding, doesn't it, of the patient and the public and what's being used for, what the data's being used for. And in CMO's annual report 2 years ago, 2016 Generation Genome, that highlighted the social contract around genomics and legitimate use of genomics data. And in many ways, that's a good example, actually, of this. When patients and the public understand what the data is being used for, and that actually there's a social contract there, but it's not just that the legitimate use of their data will improve the service that improves for others, but actually they themselves, by allowing legitimate use of their data, will enable a more accurate estimation of both diagnosis, of the treatment and outcomes. Then actually it's a win-win both for the patient and for the system.
I think we get that. I'm not sure we've made the case to the public there, but if you're
I was going to pick up, you notice that we use the term legitimate use, not sharing, because when we did some focus group work for Generation Genome, that report, what we found was when we talked to the public about sharing data, they saw in the middle of my table a giant box of Quality Street and people dipping in and taking them. That was sharing to them. And that's not what we're talking about, either then on genomics or now generally. We're talking about under proper governance, but with trust because it's been built up by good behaviour, using that data in the patient's interest, the person's interest, and everyone else's, but using it carefully, anonymised wherever possible.
Exactly. There are a number of proprietary systems that really are holding my health record to ransom. I can't see it in the way that I should be able to see it. I see the Secretary of State is now looking towards pushing primary care records into the cloud, which is a very subtle way of getting the data out of the back end of EMIS and System 1, but he hasn't done it yet, and we all know how difficult that's going to be because these guys have a legitimate reason for market share and wanting to hang on. And in your report, you talk about open source, and you talk about an entirely different approach.
Well, I don't rule out that going forward the big businesses will still be here providing us with software, but we also know that if we want to let entrepreneurs come in and other people come in with their great ideas, then we shouldn't balance the market against them, that they need to be able to access and work under proper governance and trustworthily. And that means if you have an open source basis run for the NHS, that as with other open source you can see the framework of it, you can lock into it, you use those standards, and it allows everyone to work to those standards.
I mean, it's pretty tough, isn't it? I mean, open source, I can only think, there's only IMS Maxims, I think, that do open source. I don't think anybody else does in
So I was brought up on Linux, and how good that was.
Yeah, I've got Linux on a laptop,
Yeah. So, you know, and people
Apache
improving,
and all that, yeah.
So that's the kind of thing.
Well, I mean, I think that's a really interesting point, because if you look at Windows, for example, okay, you know, Windows revolutionised everything we did, but you know, it got to the point where it's a pain. If you try and plug anything into it, you need new drivers, you need like that. Apple, on the other hand, is a closed system, interoperability, boom, everything you buy from Apple, but it works. So the dichotomy for policymakers is it not around procurement? What do we do? Do we do what Sainsbury's would do? You know, decide what they want to buy, deliver it on Monday, plug it in on a Tuesday and make it work by Wednesday? Or do we still fanny about with interoperability of what, machines or data? You're going to have the industry still trying to get an edge in the market. I mean, do we put our big boots on to do this?
But it's an important point you pick up about Apple, because you're right, it's entirely interoperable, but only within Apple systems. And I think when you were talking about the social determinants before, and one of the biggest areas for new data, which will be extremely useful to predict and prevent, is citizens-generated data through your phone. You might have an iPhone, someone else has got an Android, but at the moment those systems are unable to get anywhere near interoperability and linking up with the health system side. So I think there's a part to play. Of course, there's the leadership side from the health system to ensure that toolkits like FHIR and other interoperability toolkits are there so that entrepreneurs of all sizes and shapes can do this safely under the right governance structure. But it's also important that those who want to collaborate and work with the health system here ensure that their data systems are interoperable with the NHS and other health services. Are
we in danger, do you think, Sally, of creating the electronic Tower of Babel with all this? You know, because it's not hard to create an app. You can download a template. You know, I've done one. I've made an app.
Oh, well done.
It's not that difficult. Secretary of State's made an app. We've all made an app. You know, we have an app that measures morale in the NHS. You know, it's easy to do. But I mean, on my Apple Watch, you know, I've got a thing that does my heartbeat and my blood pressure and all that. So what? You know, who's going to look at it? Nobody's interested. I've no way of connecting with my GP. If I go to my GP,
but that's the point,
right?
Isn't it? One day you may want to monitor your BP, and then how do you download that data to share it with whoever's going to advise you on your blood pressure?
Well, I've got an app on my phone actually.
Well, let me tell you, I had to measure my blood pressure, so I did it every 30 minutes with some gizmo. I managed to get it by Bluetooth to my phone. Could I get it off my phone except by photographing the screen to give to the doctor? No.
Screen print.
It's awful.
I think we're at the sort of edge, aren't we? We've got a cornucopia of wonderful stuff that nobody really knows what to do with. If we keep giving it to the GP, there's something else for the GP to do. This says to me we want regional call centres where if you've got diabetes you're managed at the call centre, you're not managed by the GP. We have a digital first NHS.
So Salford did that.
Yes,
they were the
did.
first, weren't they? And a nurse would do it.
Yeah.
And presumably the modern way is that it's all done by computer, and only if you're out of range
You're flagged up, yeah.
does the nurse ring you
Well,
up.
of course, the opportunities. I mean, we're sitting here recording this the week before the 10-year plan is coming out a year late, so I suppose it'd be the 9-year plan. We call it just to annoy Simon. We call it the 9-year plan. But I mean, in that, I'm imagining that we're going to go back to something like regional health authorities, because they don't call them regions. It's very career limiting. Don't call them regions. But we'll have something like regions, and that gives us what, 6 million people. Manageable populations,
It would, yeah.
population health.
Yes. But I can remember working in my hospital where the region bought the expensive laboratory equipment.
Yeah.
It's your turn this year, we're buying 3 of them, it's these departments, they've got the best price, we got the best kit, we didn't have to worry about it. So I can see advantages.
Is that too prescriptive for your taste?
No, not at all. But in terms of, I think what we talk about a lot in the report as well, though, isn't it, is the ability of both the data available but also the computational advances to be able to apply specific risk predictions to specific populations, just like what you were talking about earlier. And I think whatever level that's done on, that's extremely important.
I'm just looking here at your recommendation 14, which is around it. I'm just going to read a bit of it. Develop and publish best practice standardised guidance for the NHS as hospitals, primary care and community hospitals on data collection, standards, structure, handling, storage and sharing, the development of AI tools. I mean, just drop the last bit of that off, sharing AI tools, because I want to deal with that as a separate issue. But what is your thinking about these data standards? Because there was Mike Farrell wrote a report a long time ago, and he said collect one set of data once, and made some very sensible recommendations that I imagine are on a shelf somewhere.
Yes, I'd forgotten that.
Yeah.
Yes.
Let's have another go, shall we? Okay, tell us.
Well, I'd always start the next go by getting
to...
out what had been done before.
Yeah.
But it is the concept that if you want patients to be, or the public to be able to move around the system effectively, and you don't want to get it clogged up, first of all, you can't see the data as belonging to anyone in the system. It belongs to the patient and the whole system. Secondly, you can only move it round if it's structured in the right way and collected in the right way. So you do need data standards.
In this country, as a result of the frustration of Bevan back on the 5th of July 1948, health records are actually owned by the Secretary of State, because at the time they didn't know what else to do with them.
I know.
And now...
And they're still owned by the Secretary of State,
yes,
ultimately.
Exactly. So our health records are actually owned by someone else. Now, I was in Australia last year, saw Tim Kelsey out there, where in Australia they got to, by halfway through this year, I think, any Australian who wants it will have a PIN number, and that will enable the clinician in front of them to access their health records. So you're my doctor, and you'll say, well, okay, Roy, you've got a lump on whatever it is, let's have a look at your health record, and I will give you my PIN number to access my health record. I like that.
I like that for patients, but as I'm also an academic and researcher, I want to know that that patient will let us use that anonymised data to improve not only their care but everyone else's care through generating.
Okay, well let's come at that then, and let's talk about, because that's really, I mean, data is the new oil. It's a really rich and valuable resource. We've got to persuade the public somehow or other with words other than pseudonymisation that I don't think anybody has ever heard of before the NHS invented it.
We have to, but we had a very interesting debate at a workshop the Royal Society set up for us as part of this production process of the annual report. And we've got to a position where everyone, politicians and public, think data's the new oil, therefore it's very valuable. My data is only valuable to me if I know what it means. In this modern world, I only know what it means if it's put together with other data.
Do you know,
and analysed.
That's a really important thought. Say that again.
So an individual's data is valueless without other people's data to compare it with and put it with to tell you, is it out of line, high, low, aberrant or normal?
I think that's it is a new narrative, but then to make sure that the public and patients understand why that's the benefit to them is extremely important. And it requires trust on the whole scale, though, doesn't it? And I think going back to your discussion on recommendation 14, a good illustrative example of that, and I think that's really important to show the public why does this work, rather than just being talking about data, is the Moorfields Google DeepMind OCT example.
Yeah.
And because there, one of the big challenges that a smaller company who might just be, or smaller group of clinicians with just as much innovation may not have been able to do that because of the amount of time required to clean the data, to order it and so forth. And I think there's twofold. There's one, explaining to the public why legitimate use of the data is useful, but the other is actually to show them these amazing examples, and that at the moment that's really only happening in one hospital or one or two hospitals, and showing them that why it's important, what this could mean. And that's part of what CMO aimed for this report, to actually show what this could look like if we get it right. And get
absolutely.
It right.
All right, well, let's talk about AI. We've got to get there. Babylon are having a field day with AI or algorithm. Now, there's a difference between an algorithm and artificial intelligence, because artificial intelligence is an algorithm that can correct itself, and an algorithm is just a piece of mathematical calculation that can't. A lot of people don't get that, and I think that's quite important, because you talk about both in this report, algorithms and AI.
We do.
And I just wonder really where you see, because you want regulation around artificial intelligence, but what's the definition? Does it include the algorithm and the artificial intelligence?
I think it probably does, but I want light touch regulation.
There's no such thing.
Well,
It's
that depends on the
It's
politician.
mesh and creep. We look what's happened to regulation.
But, no, I don't like regulation, but in order to look after the public, we need to assure them that what is being used is not unsafe and will not harm them.
Right. What do we really want to reassure? I'm sitting here talking to you. I'm looking out the window, and there's a bloke walking out of St James's tube station there. What have we got to reassure that bloke about his stuff? Have we got to make sure it's not going to appear on the front page of the Daily Mail?
Well, so that's the government.
Unless he's a star, when nobody's bothered. That it's going to be sold to an insurance company, and his insurance premiums are going to go up. We had that with HIV, and it didn't happen because we made the law that
we just renewed the Concord Act on genomics for the insurance industry, so we've protected there.
So there are ways of doing it.
Yeah.
And I think the key word in there that we haven't said is proportionate. So within the regulation and in the evaluation side, it's proportionate to what that algorithm.
Johnny, that's a lawyer's breakfast.
But for example, I think the difference is, isn't it? An algorithm, as you said, and remember, many guidelines that we use in clinical medicine, are algorithms, and they're set by
911.
Whereas the difference here is that it continues to learn and iterate. And what's important is that the public and the patients who use that can be assured through the evaluation of it that actually it's safe.
There's no difference between an algorithm learning and a doctor learning. Because an algorithm...
The algorithm might be better if you look at the example of DeepMind and Go.
Yeah, and the Babylon example, although it's disputed. I mean, if an algorithm becomes a learning algorithm, right, then it's like a doctor becoming it. I mean, the algorithm will make a mistake, but it will learn and won't make that mistake again. A doctor, because they're human, and I'm not having a knock at doctors, but because they're human, they might go on making that mistake until they figure out they made it.
I think AI will really help with our manpower problems on anything to do with imaging. So things like reading straight X-rays and CTs, but actually pathology. You look down a microscope, you're looking at images, and pattern recognition is somewhere that AI is really good. But we will still need our doctors, A, to train them and keep an eye on them, and B, for the very difficult, weird things where the machine, we hope, will say, don't know.
But what has the bloke walking out of the tube station got to fear?
I think what I'm after, and this is a proportionate do no harm, that they need to be reassured that someone's looked at an app that they're using or the AI that their doctor is using for them and said, it's not making a lot of mistakes, it is making fewer mistakes than a human.
Like an app that measures your blood pressure, okay, it's class 1, it's not invasive and all the rest of it, but actually, if it's not calibrated properly, it might kill you. So it's not really class 1, it's probably class 3. Discuss.
And AI is classified along with Zimmer frames and bandages. So it's not quite like Zimmer frames and bandages, but we want to know that it doesn't harm patients. And then that's one bit, and that's the light touch regulation. And then we want a different research paradigm, because, for devices generally and technology and data-based ones, you start with a prototype and then you want to continually improve it. So you need to evaluate it as you go. That's a different research paradigm from the randomised controlled trial.
We have no one that can do that.
That's why, in many ways, as you pointed out, the CMO's recommendation was to take advice on that. This needs, as it's really complex.
Yes, I did like that. Somebody actually saying we should get some advice from somebody who knows. I mean, generally the NHS is what? With the NHS, we're the best in the world. We know it all.
I think there are people who, if we put them together, and they may not be in this country, some of them will be able to advise us on the best way.
Who is good at AI, really?
Oh, we have in the Turing Institute got some wonderful people, and you should read, if you haven't, the AI chapter that, I'm going to have difficulty saying her name, Professor Van der Schaar has written, which is really hard work, but it's solid gold.
Yeah, it's tough going.
But
you should read it anyway.
Yeah. So we do in the Turing Institute have some very good people in Google DeepMind and in some other companies. Where else is good? The West Coast.
Yeah, it would have to be. Do you know what? I've really enjoyed. Time's flown by. I'm really so grateful to you both for giving us your time. It's if you haven't read it, it's a great report. It's a big old chunk. You're not going to sit down and read it in one go. But don't discount it, because wherever you work in the NHS, whatever you're doing in the NHS, there's stuff in there for you. It's a very good report, and you won't hear me say that very often. Thanks for watching.